Our next presentation is on the influence of social-demographic factors on the surgical management of pediatric liver cancer. Are we treating all children equally? By Dr. Ziagas.
Thank you for the opportunity to present our work today. I have no disclosures. Hepatoblastoma and hepatocellular carcinoma are the two most common primary liver cancers in children. Treatment involves typically a multidisciplinary approach to select the optimal therapeutic modality, including liver resection or transplantation, with or without the addition of chemotherapy. While surgery is the avenue for cure in these patients with primary liver cancer, recent studies have shown that about 25 to 33% of children with hepatoblastoma or with HCC in the United States do not actually undergo surgical treatment. With these things into consideration, the objective of this study was to examine whether disparities exist in the surgical care of children with hepatoblastoma or with HCC. To do so, we created a national cancer database from 2004 to 2015 to perform a retrospective cohort study, which included basically all patients below the age of 18 with hepatoblastoma or HCC. Multivariable mixed effects logistic regression was implemented to measure the influence of the listed sociodemographic factors on the rate of surgical treatment, liver resection, or transplantation after adjusting for the disease-related factors that you can see on the right side of the screen and the hospital-level effects. Subgroup analysis was also implemented by tumor histology. A total of 811 children were included in this study, about 81% of which had hepatoblastoma and 19% of which had HCC. Overall, about 75% of the children underwent surgical treatment. We found that patients who underwent surgical treatment were significantly more likely to be white, to have private insurance, and to reside further away from the treating cancer hospital. Additionally, these patients were more likely to have fewer medical comorbidities, smaller tumors, or have non-metastatic disease at the time of diagnosis. Also, there was no difference in the proportion of children with metastasis diagnosis among the different racial or ethnic groups. In the National Cancer Database, the most common reason listed for non-surgical treatment was that surgery was not part of the planned first course of treatment, or it was contraindicated due to patient risk factors. In multivariable analysis, the findings become even more alarming. In the overall cohort, it seems that Black race, no insurance status, or having Medicaid insurance were independently associated with decreased odds of undergoing surgical treatment when adjusting for other sociodemographic and disease-related factors. In subgroup multivariable analysis in this, patients with hepatoblastoma, Black children had 53% decreased odds of undergoing surgical treatment when compared to white children. In the subgroup multivariable analysis for only children with HCC, children with no insurance or Medicaid insurance had about 90% decreased odds of undergoing surgical treatment compared to children with private insurance. When including interaction terms to evaluate the effects of race and insurance status, the interaction term was not statistically significant, which may suggest that the effects of these two covariates may be additive. In the overall cohort, as you can see here, Black children with private insurance had 61% decreased odds, and Black children with Medicaid insurance had 62% decreased odds of undergoing surgical treatment compared to white children with private insurance. In the subgroup of only children with hepatoblastoma, Black children with Medicaid insurance had about 57% decreased odds of undergoing surgical treatment compared to white children with private insurance. And in the HCC subgroup, white children with Medicaid insurance had about 85% decreased odds of undergoing surgical treatment compared to white children with private insurance. The findings of this study must be considered within the context of certain limitations, obviously. The nature of the study is retrospective, and the National Cancer Database lacks certain potential variables of interest. Also, the National Cancer Database only includes Commission on Cancer accredited institutions that may limit the generalizability of our findings. Additionally, Children's Oncology Group member status is unknown and is not captured in NCDB, which may suggest that disparities are perhaps even worse in non-COG centers where many of these children may be treated. Despite these limitations, we can conclude that Black race and having Medicaid or no insurance status are independently associated with decreased odds of undergoing surgical treatment in children with hepatoblastoma and HCC, respectively. Further investigation is needed to better understand these disparities and address why certain children may be less likely to undergo curative surgical intervention for liver cancer. Thank you for your time. I'm happy to take any questions.
This abstract's open for discussion. One question I had, it's certainly a limitation not being able to know what stage the patients were when they presented, because certainly some socioeconomic status or race may have different stages at presentation. Did you notice any difference between those that got transplant and those that got resection only?
Thank you for the question. For the first part of your question, when it comes to stage, indeed, we do not have the pretext or the post-text status for hepatoblastoma specifically. However, we do have the metastatic diagnosis variable, which, according to our comparison among the different racial and ethnic groups, was not different for these children. When it comes to resection and transplantation, for the hepatoblastoma cohort, about 31%, about 11% of the operations were liver transplants, and for the HCC cohort, about 30% of the operations were transplants. When we excluded the transplants, the outcomes were very much similar, with not much change.
Dave Ventric of Phoenix, is there any chance that the children were getting surgery at places that were not being captured?
It is possible because the National Cancer Database intends to capture cancer hospitals and not necessarily all the children's hospitals in the United States. So it is possible.
Mary Fallett, Louisville. Politics aside, has anybody approached the Commission on Cancer about including a data point for whether or not a site is involved in the COG? So that's the first question. It seems pretty minor, like it could be included. And then the second question is, I'm sure there is a lot of frustration about whether or not we're missing something in these disparities that we see continually. Potentially genetics, or are there any other components we're missing that might be different between races and make a difference here in terms of when these patients present or other caveats that we're not considering?
Thank you for the question. Not to my knowledge, we did not approach the COG to see if that can be captured. And when it comes to genetics, again, this is not available that's captured in NCDB, but it seems like similar disparities do exist even for adult patients with liver cancer. So it would be good to investigate that further, obviously.
Okay, thank you.
Thank you.